I can introduce myself, I guess. Hi, it's Courtney Van Houtman from Duke University and the Durham VA. I'm really grateful for the invitation to come here today, and I'd be happy to talk about NIH-funded work, of which I'm very grateful, but I'm going to really focus on put my VA hat on and talk about some of the exciting advances in VA policy and around caregiving. I want to thank recent collaborators, first of all, for inspiring some of the comments I'm going to talk about today, and particularly our key operational partners in the VA healthcare system who are here today. Meg Cabot, the National Director of VA Caregiver Support, and her colleague, Meg Campbell-Kotler. We also have at least 2 caregivers of veterans that I'm happy to see in the audience, and we may have other caregivers of veterans as well here. But there's a lot of exciting things going on in VA caregiving policy, so I'll talk about some of the funded work both in policy evaluation and in research that I've been doing in this space with all these other folks here. I'm going to address 3 basic questions in this plenary. How does policy affect caregiving? How can research best inform policies to support caregiving? And then what are the top policy additions that could improve the caregiving experience? First question, how does policy affect caregiving? In 2010, the most sweeping caregiver support policy nationally was passed that we've ever seen before in the US, the Caregivers and Veterans Omnibus Health Services Act. This law established 2 main programs of support that the VA Caregiver Support Program would manage in VA Central Office. The Program of Comprehensive Assistance to Family Caregivers, or the PCAFC, which is for caregivers of eligible veterans who were injured in the line of duty since 9/11. And then secondly, the Program of General Caregiver Support for caregivers of all veterans in need of a caregiver. I want to give you some more information about the PCAFC, this program for post-9/11 caregivers. This is a clinical program that provides services directly to eligible caregivers. The top row shows some of the benefits specific to this PCAFC recipients, and the second 2 rows show things that general caregivers can have access to. To be accepted into the program of the PCAFC, caregivers have to take part in mandatory training called Building Better Caregivers. And if they are accepted into the program, they receive a monthly tax-free stipend that is the amount of which is set by the intensity of their caregiving, and it's valued at an average home health aid rate in their area. They can also get health insurance through CHAMP VA. It's a VA insurance program if they don't have insurance previously. This program is incredibly comprehensive. The main point of contact for it is through caregiver support coordinators who are located at every medical center, so over 140 medical centers nationally. And at the larger centers, there could be up to 5 caregiver support coordinators, and they're the real points of contact out in the field for this program. Caregivers can get mental health services, can get access to respite care, be reimbursed for travel, access a caregiver support line. And it's not on this slide, but I want to just throw out a website to you because it's incredibly valuable for all of you interested in caregiver training or testimonials or resources that you could look into. www.caregiver.va.gov. It's an amazing website that has a lot of resources for researchers and caregivers themselves. The assessors for this program determine whether it's in the best clinical interest of the veteran when making their decisions about participation for caregivers and support the veteran's progress in treatment. Demand for this program has far exceeded expectations. Over 23,000 caregivers have participated, and outlays to the government of $1 billion have been spent. With this increase in demand way over what was expected, our partners in the VA Caregiver Support Program sought help from researchers, my team, in the Durham VA to understand the short-term return on investment and also areas of potential improvements within the confines of the law. So summing up the last 3 years of my life in 2 slides, I want to show you what we found in terms of the short-term impacts of the PCAFC, that is the program for the post-9/11 caregivers, and on important outcomes. We found that participation in this program increased access to care for veteran participants at 1 year. And these are in high-value types of care, such as primary care and mental health care. The participants in the program have very high rates of PTSD and mental health issues, as well as physical injuries, so it's really great that we found they could have higher primary care use and mental health care use. We found no increases in acute care or emergency department care. At 3 years, we found that veterans of caregivers who were in the program had increased costs of care to the VA around $2,000 on average. This goes along with that increased access story. Our survey research found that there were promising trends towards reduced caregiver depressive symptoms and financial strain from the PCAFC. Finally, in-depth interviews with caregivers, we interviewed over 100 caregivers nationally, found that they really valued the PCAFC supports, and they were particularly grateful for flexibility to stay home with the veteran and learn about symptom management skills, and that the help from the caregiver support coordinators, those points of contacts at the medical center level, were really helpful, especially in navigating the VA healthcare system. We also found a couple areas of particular where improvements could be made. In our evaluation, caregivers, both before they took part in the program and after, felt poorly integrated into the healthcare team. This has come up a lot today in other people's comments. The caregivers thought that there was poor communication with providers to them directly, little regard for their capacity for their caregiving role, and little regard for their preferences. We did find improvements after they participated in the program, but still pretty low integration. And this is based on a measure that I have developed with our partners and also other researchers like Jennifer Wolf in the room. We also found that respite care benefit, while available to all caregivers in the PCFC, was not used extensively, so we made some recommendations to our partners for potential refinements. Overall, the results of this evaluation of short-term impact showed that the PCAFC meets a critical need of veterans and their families. I want to go to the second question: how can research best inform policies to support caregiving? I believe that a really powerful strategy is by embedding researchers in the healthcare system and in operations and policy offices in order to move us towards a caregiver-friendly health system. This term, caregiver-friendly health system, is inspired by Johnny Hartford colleagues' work, Fulmer and Berman, who've laid out the different components that are necessary to move us towards an age-friendly health system. And two of the components that they lay out, I think, are particularly important for moving us towards a caregiver-friendly health system. We need a healthcare system that promotes physical function and independence for care recipients and for the caregivers. Without high-functioning caregivers, we can't have high quality of care or high in the encounter, much less in the home. We also need a healthcare system that recognizes and explicitly supports the needs of family caregivers. And we have ways to go in this, even though we've made great advances in the VA in recent years. Why do I think partnered research can help us move to a truly caregiver-friendly health system? As researchers, if we partner with the decision makers, we can really help identify from the outset of designing our research studies the barriers to caregiver-friendly care that the decision makers face. What is in their way of implementing your great idea? We can also reflect the incentives that they make. What is it that they need to achieve? Do they need to reduce rehospitalizations by supporting caregivers, or is it something else that they want to achieve? What do they need to make their business case to pitch your program? By working in partnership with decision makers, that will help us move to concrete, usable policy recommendations and hopefully spur on policy action or healthcare delivery changes that facilitate caregiver-friendly care. I want to give an example on a very modest level of some research that I've done in partnership and that helped to spur some healthcare delivery changes that I think facilitates caregiver-friendly care dissemination. As many of you know in this room, there are a lot of experienced trialists that I'm looking out at. It's very difficult to design caregiver support mechanisms that have extensive reach, that target caregivers most at risk of bad outcomes. Getting people who are really at risk, it's hard for them to take part in research for either trust issues, they're totally overwhelmed, they can't afford to come in to the hospital because they don't have the gas money to take part in your program. It's also really difficult to show large effects, what Richard Schultz has called clinically meaningful significance, instead of just worrying about statistical significance. Even though we know inherently that our programs are very valuable to caregivers, it's really hard to show this in the measures that we have available to us. So I thought if I'm ever going to have a chance to improve and try to surmount some of the challenges that people over the last 20 years have also faced, that I knew I needed to seek support from decision makers in the VA healthcare system as I tried to roll out my own randomized control trial. So I invited stakeholders from multiple VA program offices onto a study advisory board in the grant writing process. We have people from VA Caregiver Support, we have people from geriatrics and extended care, we have people at the region level in the VA, that's called a VISN, social workers and nurse leaders in that process, to help me develop curriculum design for the classes establish how we can have a warm handoff to existing VA services at the end of the caregiver support skills training program, as well as to think, Courtney, you're just crazy if you think this is feasible and there's no way this is going to come up to scale. So I ask that question often, is this scalable if it is found to be useful of the study advisory board? The resulting trial that was fielded and recently completed was the Helping Invested Families Improve Veterans Experiences study. This is a funded study in the VA from HSR&D. This is a skills training program for caregivers of veterans referred to home and community-based services. So we caught them at a particular breaking point where the risk of institutionalization we felt would be very high. And these people who were referred to home and community-based services, the veterans, they had either functional limitations or cognitive limitations. So there was no index disease, so it was somewhat unique from a lot of the caregiver trials that choose one disease state. This is a 2-arm trial. The High Fives arm received 5 targeted phone calls from an RN where the caregivers decided the topics from a set list of 12 topics on self-care, caregiver-focused topics, as well as patient or care recipient-focused topics. And then they also attended 4 weekly group sessions taught by an RN. And the last class was taught by the VA Caregiver Support Coordinator, again, trying to link them into existing services at the end of their experience. The usual care arm simply received information on existing VA Caregiver Support Program services, that website I told you about, the support line, and the contact information for their local Caregiver Support Coordinator. We don't have the full results. Our primary outcome here is days at home over 12 months, and we are currently analyzing that. We also don't know yet what the trial results are in terms of cost of care. But we did find that participants in the High Fives arm had significantly higher satisfaction with VA care quality, both from the caregivers and from the patients. We collected this information. And we think it's in clinically significant terms, in terms of a 0 to 10 scale, half a point increase in satisfaction with VA care quality was found for both caregivers and veterans. And this was at 6 months and at 12 months. We found that the intervention had no impact on ameliorating the high depressive symptoms that we had in our population. I think this goes along with what other people are saying, that we need much more intense interventions to address significant caregiver depressive symptoms. Our qualitative results were very compelling and also echo some of the themes we've heard today about isolation. Caregiver said, I finally felt like I was not alone. I spoke up to the doctor and got what I needed. I got mental health counseling and things roll off my back now. This speaking up to the doctor and the mental health counseling reflected in our view that we spent a lot of time focusing on how to communicate better with the healthcare team and also how to take care of yourself better. So even without results from this trial, how did I use this trial to get towards healthcare delivery change in partnership with the VA? Independently, while this trial was going on, and because of the partnership that we established with them, the VA Caregiver Support Program had identified important unmet needs for training in this High Fives population, that is, veterans with cognitive and or functional impairment over the nation, and those caregivers had some unmet needs for training. But because of the long-standing partnership with them, they were willing in the office to partner with our research team, and we pitched a project and won it in order to implement this program at 8 sites nationally as a part of a larger 5-year project called the Function Query, which is an initiative to optimize function and independence among veterans and their caregivers that we're undertaking in the Durham VA. So I really do think partnered research can help move us to a truly caregiver-friendly health system, but we as researchers have a strong role in being willing to take on more risks. We need to be more willing to pitch our imperfect programs to decision makers and stop waiting for the optimal study to arise and these pristine p-values that we obsess over. What may be effective to partners is maybe different than what we think of as researchers. We want it to make a difference, of course, but we also may need to think about pragmatic, useful, and evidence-based programs that can fill an unmet need, that can help decision makers make a business case. And these are not always cost savings. And I'm an economist. It's hard to know it's not always cost savings, but it really isn't. But I think if our research aligns with decision-maker needs, partnered research has the potential to make a real difference in creating a caregiver-friendly health system. The third question that we were tasked with is, what are the top policy changes that could improve the caregiving experience? For me, policies that achieve a caregiver-friendly health system should be a very high priority in the market basket of things that I hope we see moving forward as we finally have some traction behind policies for supporting caregivers directly. We need to better integrate caregivers into the healthcare team. And we need to incentivize providers and healthcare teams to do this. Otherwise, they're very busy people and we're not going to see change. We need to incentivize check-in capacity, emotional and financial strain of caregivers, and we need to address these issues. We need to also incentivize use of caregiver navigators and caregiver support coordinators like the VA has enacted. We also need to increase training and supports across many different clinical settings, but we have to incentivize this too, to have dispersion of pragmatic, useful programs. And then totally off topic from the comments I've made so far, I want to put on my economist hat and say that I really do think that we also need policies that increase choice in long-term services and supports. If the choice is to use family caregiving, then I think we also need to strategize and think collectively about how to minimize the negative economic consequences of caregiving, because they're so linked into caregiver emotional well-being. Thank you very much.
Thank you.